Welcome to The Bridge, the official podcast for the University of Maryland, Baltimore School of Pharmacy Patients Program. The Patients Program is the bridge between the community and researchers. The Patients Program created this partnership to help researchers listen to the community's voice in order to build a bridge to an effective learning healthcare community. Here's your host, Rodney Elliott.
Hello, Dywan. How are you?
I'm good, Rodney. How are you?
I am fantastic. I want to thank you for joining us today. I'm going to apologize in advance if I stumble over a word or went to the dentist this morning and I thought I was just going for a regular cleaning, but I'm feeling it. I'm numb on one side. It's coming back, but
you sound okay.
Okay.
I can hear you good.
Today, we are honored to have a friend of the program who's been with the Patients Program for a while now and has played multiple roles with the Patients Program. Most recently, Dywan, I had to admit, I have enjoyed your contribution to the PPA, Patient Professors Academy.
Yes.
We're in our second year and we presented on a panel, but every time I've seen you in the square, again, we're talking about on Zoom, you've contributed awesome information and awesome knowledge to our attendees. And I think that's attributed to the fact of the matter that you've been with the Patients Program for a long time. So
yeah, it's going on maybe 12 years.
12 years.
I think so.
That's longer than I've been here. I guess that kind of leads me off to my first question. Talk a little bit about, for one, who you are and what you do, and then how you felt as though you can be a long-standing, over-decade partner with the Patients Program.
Sure. My full name is Dywan Monroe. My family calls me Dywani. Go figure. Still, I'm 55, still to this day. That's what they call me, but that's fine. That means they love me, right?
Sure is.
I was a former community health worker. I'm not sure if everybody knows what that is, but community health workers are people from the community who are that go between, that intermediary between the health and social system and the community to make sure that people who are normally under-resourced, underserved, marginalized get the care that they need when they're managing chronic disease, acute disease, and they played a really good role, particular role in the recent COVID epidemic. My role, I work for an organization now called the Institute for Public Health Innovation. It is a public health institute, one of about 45 around the country, and the overarching role for our institute, which is regional, so we cover DC, Maryland, and Virginia. And our main mission is to support organizations like hospitals, community-based organizations, health centers, but mainly the community, understand and figure out how do we move from health equality to health equity. What does that mean? And then we provide opportunity to be this neutral convener. So when I interject my information and things like that, I'm not beholden to a university, a government, or anything. I can just say what is actually happening in the community and what we need. And so my wonderful role from CHW to now training manager, I became a master trainer, and now I'm the training manager. We've trained over 1,000 community health workers in the last 10 years.
Wow.
And it's really growing. Recently, the CHWs, that's what they're called, is the go-to now health professional, because they are professionals that hospitals, community health centers, public health centers are looking to really change how they do healthcare and public health and impact those social determinants of health for people, particularly of color, gender, who have been marginalized. So I am so happy to have gone from being boots on the ground to now supporting boots on the ground and a huge advocate for what community health workers do. And my organization works in other things like food insecurity. We're working recently with seniors, and also we're just now getting into understanding that violence is a public health issue, and we're trying to impact that as well. So thank you so much for having me. And I think the other question you asked, how did I get to the patient's program? It's interesting. Before I started where I am now, I was a community health liaison with a pharmaceutical company. I'm not going to say the name.
Okay.
But my role was not to sell drugs. It was to connect patients to resources and to help providers connect patients to resources that will support them outside of the medical piece. A lot of people were struggling with food insecurity, housing, all of these things that impact someone going to the doctors, get their medicine. And so I was helping those providers that were connected to through the pharmaceutical company, to connect patients to resources. And in those meetings, those initial partner meetings that I reached out to, Dr. Mullins, who is, the head of the patients program, he started coming to my meetings, and he was a great contributor. And so Dr. Mullins came to me and he said, would you want to participate on a board to just look how do we get community to ask the right questions about research? And my background was initially, when I was at CHW Hopkins, it started in research. So that was one of my areas. And I was like, was very honored that he asked me. And then from that first meeting on that we had, he really looked to the patient's advisors and the community to really support getting the community to understand, but not just getting the community to understand, having the community be a voice as a part of it's shaping research. That's the thing that kept me.
Yes.
Because I think that is so key. Just like as a CHW, you go in the community, you're not telling people what to do. You're motivating them to use their own assets and abilities to become their own advocate. It's the same thing. Dr. Mullins went into the community and he said, what do you want us to do? What is important for you? We're listening. We need your voice, but besides your voice, we want to be here as a living partner to really support what's happening in the community. And that made that dialogue just easy because he was genuine.
I think.
Right? And the team was genuine.
Yes, that was one of the first. That's kind of how I was introduced to Dr. Mullins as well, from the standpoint that he knew that I wanted to get into working with the community in some form, fashion. And he knew that having people join him with the patients program to be that gap filler is important because, like you just mentioned, you have the opportunity to stand in a gap, or in most instances stand with the community, to share what they're going through, their lived experiences, and that they typically don't be in.
Right.
And that kind of leads me to my next question. You've been doing this for a while now and have had a lot of experience doing it. Can you talk about some of the benefits of this partnership with the patients program from both?
Sure.
I mean, what have you seen from the community's perspective that they've learned, that they've kind of changed their ideals and thinking? And same thing for the research side. Like, how has your partnership helped change the way people, or maybe shift the way people think about research?
Sure. So let's talk about the community side. It has been amazing what I've seen throughout the process of being on the patients program. I've been at the advisory level, but I've also am a patient. I live with diabetes and hypertension. And so that was another reason why Dr. Mullins wanted me to also be a part of the advisory, because I'm from the community and I'm living with a lot of what a lot of people are, particularly women of color, are living with some of those diseases that need more support, particularly around the social determinants, those things that may impact my health. Can I get to the doctor, right? Am I eating the right foods? Because I am a diabetic. Am I taking my medication? And so throughout the patients program, I have met a lot of community people. I met more community people through that than I have kind of when I was with CHW.
So you met more people with us as opposed to when you were actively doing boots on the ground?
Absolutely, because when I was CHW, it was a targeted focus just on Black men in East Baltimore, right? And I've met their significant others and everything. But when it came to the patients program, I'm not only meeting community people, but I'm meeting also allies of the community, partners, other health professionals who are from the community, who believe in the community, but also respect the community and make sure that their voice is not just heard, but what they say is actually implemented.
Yes.
Coming from other institutions that I've worked for, I've seen a lot of dog and pony shows. Let's bring in the community, and then they go and decide to do what they want to do. This program is way different because they started with the community first. Instead of coming in and saying, oh, we need your feedback about this, the Patients program said, you know what? We want to be here in the community. And while we're here, tell us how we can be of assistance.
Yeah.
And then as we are here, we know research is something that a lot of communities, particularly people of color, we know some of the history around research is really tainted and people are not trusting. Even when I went out as a CHW and I was working with Black men in hypertension, and I would meet their families and they would be like, oh, you're from that place where they snatch people off for research. So I had to actually get through to build trust and rapport, and that's the thing. To people to know that I'm there for them is not about the historical piece, but as we are moving forward, it's changing.
Dywan, you said building trust. That's something that in my role as the engagement specialist is what a big part of the work that I do out in the community is that building trust. It's recognizing that helicopter research still does exist as a term that's used a lot in this field of work that we do, meaning researchers typically, not all, but typically have had the experience of flying into the community, getting what they need, getting back out of there. We don't participate in that. That's something that the community lets us know is a super uber red flag.
Yeah.
We recognize it right away. But this kind of leads me to my next question. When you talk about you don't necessarily have or is as active when it comes to boots on the ground, but you are an advocate for community members. You're an advocate for yourself, to be quite honest.
Yeah.
Your lived experiences. What has been your biggest pivot in your healthcare journey as a patient caregiver and an advocate?
My biggest pivot was advocating for my mom before she passed and making sure that she became her own advocate. A lot of times we would go to the doctors and she would sit with the doctor. I'm sitting on the side and she just sit and look at me. He would talk, she would say anything, or she would go, And I would have to, number one, I had to have a conversation with the doctor because I talked to her. I said, why are you so standoffish? I know you don't like going to the doctor, but you know we have to be here. Well, I don't like that he got that computer. He clacking. He's not looking at me and paying me attention. Oh, so I pulled the doctor aside and I told her, look, if you want to get what you need out of my mom, you have to be personable. She loves people to interact with her and be personable. If that computer is a block and it makes her shut down and she's not going to respond, and I want her to be able to advocate for herself, even though I'm here to help her. So we came back for another appointment, and sure enough, he had the computer behind him.
Yep.
Pen and pencil like they used to do. And he's like, hi, Miss Monroe, how you doing? And he asked about, things going on and the god babies and her nieces and everything, which she loved to talk about. He went in and then she just started, right? So I supported her to understand what was going on and not connect to the physician. And he listened. It changed the whole trajectory, of taking care of her health, even though she did pass. But prior to that, there were things that she was able to change and do for herself that she couldn't do before. And then for me as a patient, I've always been, let's say, mouthy. My mother told me I should have been a lawyer, but I have always been a person that stands up and advocates for themselves. I'm an only child, so I had to be in that space of, if I'm not going to do it, who is?
Yeah.
So I make all my providers accountable. They know me. They know when I walk in the room. Don't start with you got to lose weight. Did you take your medicine? You start with checking in who I am. And then we can have that dialogue. So that is how it's been shifted. Yeah.
That's important. I mean, you hear that a lot. And I think from the researchers' side, from my experience, they come to understand that we understand your research is important, but before you get there, meet the community members, meet the people you're going to be engaging with, and come down a little bit. Come down out of your ivory tower, take off the lab coat, sit and have a conversation with us.
Stop the jargon.
Because that will make the process that much smoother. And I tell people all the time, like, look, you want to leave a good impression.
Absolutely.
Whatever you're dealing with, we're talking about a community health worker, we're talking about a stakeholder in the community.
Yes.
Patient, because once you leave and once you go, you want them to speak highly of you.
And come back.
Come back and refer you.
Right. And they don't mind helping you because they know that you made it safe and okay for them to have a voice, and the voice means something, not just on the paper. Yeah.
Not only your voice means something, but your lived experiences are just as important as the letter. Absolutely. All the letters and letters behind your name. Dr. So-and-so, PhD. That's great. But you know what? The lived experiences of the community members are just as important in this process.
And that's why community health workers are so important. Their lived experience is 50% of why we hire them.
Okay.
You have to just live there. You may share the same disease state. You may have been a caregiver, but your lived experience is why we hire you. And then we just train you to utilize that in an effective, appropriate way to make sure that you're motivating people to change, not making them or fixing people to change. It's different.
Yeah, it is different. It is different. This is an awesome opportunity to want to speak to you here on the Bridge podcast, where we are an extension of the Patients program when it comes to disseminating information, and I share with people all the time that it's an opportunity for me to talk about the relationships that we've established, talk about the relationships that we've sustained with our community members, but also our researchers in a different way. And this question was brought up by another colleague of ours in the podcast space, and when he mentioned it, or he asked me that question, it had me thinking a little bit, and I said, wow, I think I may take this question sometime and ask some of my guests. When did health become vital for you?
I think it became vital the day I was diagnosed with diabetes. Seriously. I mean, prior to that, it was like I was going to school, I was working, I was worried about taking care of everybody else. And then I was diagnosed with diabetes. My A1C when I went in was 10. And I didn't really know about it that much at the time. And back then they weren't talking about pre-diabetes, right? So the doctors didn't even know back then. That's how, far back it was. And then when I realized that after I went through with a great physician who walked me through what I needed to do, showed me I had to stick myself with a needle for the first time. And he's like, your diet is going to change. So after I left that meeting, I actually had to go to the grocery store because I didn't have any food in my house. And I went in the grocery store and I'm walking around looking at the stuff that I normally would get. And I stood in the middle of the store and I said, what the hell am I supposed to eat? Right? Because at that time, I really didn't know. So they signed me up for a class. I got the education and I was very diligent about making sure that I was not going to stay in this space of diabetes. But that really made me focus more on my health and the health of my family and others, even though I was a community health worker and I was focused on health for everybody else. But sometimes you forget about yourself, right? That stuff here goes out the window because you're helping everybody else.
That's important. We got to make sure that we are taking care of ourselves because
I can't take anybody else. I'm not well, right?
You can't pull from an empty cup.
Absolutely.
And I'm not trying to get religious or not trying to get anything that.
No, that's on my Facebook page. Trust me, with you.
You can't pull from an empty cup.
Absolutely.
Dywan, you've been around research. You've been around being advocating for community members for a while. You have tons of experience, good, bad, ugly, and indifferent. I know, again, in our role or my role as the engagement specialist or the patients program in general, we just try to explain the importance of research to both sides. And when I'm talking about sides, I'm talking about the research academia side. I'm talking about the community side. The next question goes to that researcher and that community member who are kind of on the fence, right? The researcher that's on the fence about how to connect with the community and wanting to do it their way, but just isn't getting results. And that community member who was like, okay, here we go again. They're coming in here again with their clipboard, or they're coming in here wanting to get information, but not. What would you say to both of those folks who are on the fence? Like, should I participate in research or should I not? Or researchers, should I listen to what the patient program is talking about? Should I listen to what Dywan, who's had a decade of experience being a community health worker? Those people on the fence, what would you say to them?
Let's talk about the researcher on the fence. The first thing I would say to them is, before you think about an idea, go to the community first. A lot of times what they do is they have the idea, they look at the research from previous of the studies, and then they make the hypothesis. And then they want to design things. And then like, oh, so since we have this, now let's see what the community says. Let's say as soon as it pops in, go out into the community. And when I mean go out, I don't mean send something online. I don't mean send a newsletter. I don't mean send an email. Get your butt out of your chair, and go out into the community. Now, if you're scared, then you understand and find who are the community gatekeepers, right?
Call Ryan in your patients program. We'll connect to the community.
Exactly. Because unfortunately, some people, because they are not from and don't live in those communities, and we know the media paints a lot of certain pictures of certain communities, researchers, they won't tell you, but they're scared to go. They don't want to go. They don't want to go by themselves. And they feel as though if they go, there's about to be physical harm. And if they're not of the same race or ethnicity or share the same values, they're going to be judged from the community, and they know the community has this understanding of the history of research.
Yeah.
So they need to make sure that they, number one, are genuine. Is it about the research, or is it about the community you want to support? Right. Because even if you come correct, but you're not genuine, the community will take their foot and kick you out.
Yeah, true. Very true.
And for the community, I really say if they're on the fence, hold them accountable. Hold the researchers accountable. So if they come to you with wanting to understand or having this idea, or if they want your opinion, not necessarily what's in it for me, but what will you leave? When we talk about helicopter research, they don't leave anything.
Yes.
A lot of times they bring these wonderful interventions, free medicine, literature, access to all kinds of services and stuff. And then when the research is over, all that's gone. So the person is back at square one.
Yeah.
So you fill up the community and then you drain it out when you leave. No community wants that. If you fill us up, keep us filled. Show us how to fill ourselves.
Yeah.
Right? And to be able to have that dialogue.
Keep us filled and show us how to keep and fill. Oh man, that's an awesome piece.
Yes.
Yeah. But it makes all the sense in the world. Our patients program have the opportunity to work with a lot of researchers, and we have seen some of that work follow through. I love when we do get researchers interested in working with the community, and they do just that. They come in the very beginning, to the point where now some of the community members are actually part of the implementation of these.
They work alongside. Yeah.
They work alongside, and that is great, because now as a researcher you have someone who literally walks the walk in that community, right? They can speak to what the community as a whole is thinking, and they can help you shape your research. And you know what? That provides them with clear, straightforward research, but it saves time also a lot.
Yes.
Saves time.
Yeah, one of the things, the first thing I learned as a community health worker, and it resonates to me now in all the spaces that I am to support communities, is that I was told from a mentor, even though the problems are in the community, the solutions are there as well. Because a lot of times we see the problems and we look at other places for the solution. You need to go back to the community, because they will let you know how to do it right.
Yeah.
And if they don't know how to do it right, they will explain in a way that will lead you to understanding how to work with them and collaborate. Because a lot of times as higher up institutions, we don't like to collaborate with the community because we serve the community, right? So they're used to serving and not used to collaborating. So this is different for researchers. But now we need to get researchers to just like you collaborate with other researchers, you need to do the same thing with the community.
You're part of the team. When you work with the patients program, we're going to make you feel like you're part of the team.
Absolutely.
Of research. And that starts with boots on the ground. It starts with engagement. That starts with back and forth dialogue. Before we get out of here, Dywan, talk to us a little bit about what you thought the PPA was going to be, I guess, when you first heard about it.
Right.
You being involved with it for the second year, how that's been a contributing factor to the research space.
All right. So initially, I kind of thought what it is going to be that we are training people to understand the best way to engage in community and to work with communities to do research.
Okay.
But as we, in the second year, the first year, my session was on equity, health equity. So I did it with Dr. Claudia Beckay, one of my mentors.
Oh, man, she's great.
Yes, she is awesome. And addressing, not only did the PPA talk about engagement with the community as a way to really speak to supporting research in those communities that are hard to reach, but it also talked about a lot of the issues around why engagement is hard, such as health equity. Realizing that 2023, people are still, because of either the color of their skin, their gender, their sexual identity, where they come from, their language, are still not receiving the support within the healthcare system, even within public health and some of the social systems. And realizing that because of that, it adds another layer of mistrust for the community to really support research. But what the PPA did was to not only do that, but explain what research is and what it can be. It doesn't have to be what it used to be. And realizing that the community is a big part of making it look like what it should be, so that the community feels like my contribution to being a part of this will help my grandchildren and their grandchildren.
Yes.
Future, when it comes to not just medication, but behavioral types of interventions. Because research is not just about drugs, right?
Right.
It's about also utilizing people like community health workers in spaces where people normally don't utilize them.
Yeah.
So I love the fact that my journey as a CHW was a part of research, because I got to see both worlds. Because before that, I was skeptical about research. I learned about it in college, and I learned about the goods and the bad. And I'm just like, But I became a CHW as a part of research. So I did that purposely to make sure that I knew exactly what we were doing, and that what my role was not being a person that was taken advantage of or not supporting the community. But what I did as a CHW made a difference to the community. And when our study was done, what we decided was we wanted to transfer what we did back into the community. And we did that at least for a year after the study was over.
Yeah.
So we were trying not to be helicopter researchers, because we knew a lot of the men who were in our study, they were doing well. We had a 92% retention rate over 5 years of men taking care of their blood pressure. We didn't want to stop that. So we connected to community partners, and we did. And instead of me going to the clinics, I was going down to the community partner sites, checking blood pressures, making sure people taking their medication, helping them get jobs. I was doing the same thing, but we transferred it. And that's why I'm like, that's how it should be done.
I think, Dywan, for the first time I met you, I'm pretty sure it probably was over Zoom. Your energy towards being a community health worker, to standing in the gap for people, it's kind of always been the same. And you, and like you said, you're an advocate, but you're also a patient. So you've always still dealt with your health issues, but always been a shining light in this space. And I want to commend you on that.
Thank you.
Like I said, when I first met you, even to now today, and everything in between, when I see Dywan or I hear Dywan is going to be in the meeting or email, her energy is always there, and she doesn't have any problem at all with letting people know how
don't.
she feels.
You heard me, Rodney.
Trying to get across. So I appreciate you for that, Dywan.
Thank you so much. I appreciate you. I appreciate being a part of the patients program. I appreciate Dr. Mullins. It's been a great, wonderful experience.
Before we go, I got one more question I'd like to ask all my guests. For those who are listening, The Bridge is a podcast that's part of the Patience Program, and we're here in Baltimore, Maryland. And Baltimore is real special to us. If you're a Baltimorean,
yes, born and raised West Side.
I'm on the East Side, but no matter what side of town you're on, you have you know the importance of Baltimore and what it means to us being homegrown folks.
Yes.
My last question to you is not necessarily research related, but just Baltimore related.
Okay.
If you had a chance to have dinner, glass of wine, even a good old Baltimore snowball, who would you have it with, dead or alive?
UB Blake.
And why?
Do you know who UB Blake is?
I do.
Okay. I met UB Blake at least, I think, a couple months before he passed at an event. I just got to shake his hand, but I never got to really, I always wanted to like just sit and listen to him talk. I've heard the music and everything, but I wanted to that would be great to just have an opportunity to just sit, because I love my seniors, right? And when you're in his presence, it's great to see him on TV. When you're in his presence, it's a whole different thing. So I did get to shake his hand, but I would like to sit down and have a snowball. Have even like Blake.
That's great. Yeah. It's great. Evie Blake is fantastic, and sitting in the company of seniors is great. Dywan, again, I thank you. I appreciate you for joining us today on The Bridge.
Thank you, Rodney, for having me. I appreciate it.
Thank you for listening to The Bridge podcast. To learn more about the Patience Program, visit our website at www.patience.umaryland.edu.